Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. Welcome back to Open Mics with Dr. Stites. Today, we're focused on men's sexual health, especially as it relates to prostate cancer. For many men, a prostate cancer diagnosis can bring fears, primarily about survival, but also about quality of life, including sexual function. And just to let you know right now, today's show includes discussion about things that might make some people blush, like sex, erections, and erectile dysfunction. Now, if that didn't get your attention, I don't know what hope we have here on the holidays. These discussions normally happen in private. They do make some people uncomfortable, but the candid conversation we're having today can help end the stigma and ultimately help someone. But first, let's do morning rounds. We know that cancer these days is more survivable than ever, thanks to advancements in treatment, prevention, and screening. But a new study asks the question, is it the treatment or the prevention and screening that is saving more lives? This provocative paper was published this month in JAMA Oncology, found that improvements in prevention and screening are saving way more lives than treatment. From 1975 to 2020, in 5 common types of cancer, medical advancements have averted 5.95 million deaths. 80% of those were averted due to prevention and screening, though. Helping me explain this is Dr. Christy Brown, who is not involved in the study, but she is a cancer researcher and co-leader of the Cancer Prevention Control Team here at the University of Kansas Cancer Center. Dr. Brown, this study only looked at 5 cancer types. What did the study focus, or why did it focus on those cancer types and sites?
First of all, it's great to be here, and what a wonderful study to be talking about. So this study focused on 5 cancers that are probably some of the most prevalent cancers out there. They're also associated with some of the highest cancer-associated deaths. So not only were those cancers most prevalent, but they also had clear approaches or strategies for prevention, early detection, as well as treatment. So over that 45-year period, investigators had a wealth of data to be able to directly compare the impact of those approaches on outcomes, especially cancer death-related outcomes.
You know, it's great that treatment saves lives, but why is it so important to put that focus on prevention and screening? Although I'm just going to say it out loud, I'm one of those guys that had prostate cancer, and this guy right there helped me. So just full disclosure, I'm a believer in this whole prevention thing because it helped me. But you talked to us a little bit about why it's so important for us to get that focus on prevention and screening.
So it's important to acknowledge the advances that we've made in the treatment space, you know, especially more recently with immunotherapy and other types of treatments, which may not have, you know, been assessed in this study in particular. That being said, you know, we know that early detection, so catching a cancer early, actually leads to better outcomes. So this means less cancer-associated death. Prevention is a whole other ballgame. Imagine the impact of a cancer diagnosis. This is a psychological, a physical, and an economic impact of that diagnosis, not to mention the cancer-associated changes or impact on lifespan. So being able to eliminate, you know, that initial cancer diagnosis is clearly going to have a long-lasting impact in these patients.
So one big change that since 1975 is that smoking is less common, although I don't know if that's completely true in teenagers, or especially if you think about some other forms of inhalation. But how big of an impact did that have on the study, do you think?
This study really highlighted that, you know, approaches that were introduced during that period had a huge impact. So smoking was the #1 factor, or reductions in smoking was the #1 factor that contributed to aversion of these cancers. So it's estimated based on their models that we've averted nearly 3.5 million lung cancer associated deaths. And it's almost uniquely attributable to prevention strategies. So smoking cessation efforts, as well as a reduced uptake in smoking itself.
It's a pretty darn big deal to get that many deaths to be averted from telling that story about prevention. So what a success story that is. Now, if you had a crystal ball, though, what are you going to think that the next big cancer prevention success story is going to be?
So this study also highlighted impacts on cervical cancer. And it was about 100 years ago that Dr. Papanicolaou in New York City discovered that cervical cells actually change. And by the 1940s, it was established that they could use methods that visualize cells of the cervix to be able to predict whether there was transformation of these cells that could lead to cancer. And this is what we now know as the Pap test or the Pap smear. By the 1980s, it was established that certain forms of the human papillomavirus were largely responsible for the majority of cervical cancers. So now we have these methods of early detection, including the Pap smear and PCR test for the presence of the HPV virus itself. And it allows us to be able to manage patients who have these positive tests, really allowing us to prevent the development of cancer in the first place. Now we know about, or we're going to hear about a little bit more about at-home sample collection for HPV testing, which is going to really change the game as far as being able to reach a larger part of the population. And probably the biggest breakthrough when it comes to cervical cancer prevention is the development of the HPV vaccine. Now, this is a vaccine that will prevent infection and transmission and is administered to both boys and girls before they become sexually active. So this not only will reduce the risk of cervical cancer, but many other HPV-related cancers from developing in the first place.
Yeah, that's a really big deal. Can the HPV vaccine be administered later in life? Let's say somebody has gone through divorce or lost their spouse and is going to be more sexually active. Can they go and get the HPV vaccine then?
It's currently not predicted to be effective in those populations. Okay. Unfortunately, a large proportion of the population has already been infected at some point in their life. And this is something that usually clears after a couple of years. And being able to monitor the presence of this virus over time actually allows us to prevent or to take preventative measures for cancers developing. But currently, it's not advocated for in older populations.
All right. Well, thank you, Dr. Brown. This is an outstanding information. We appreciate you being on the program thus far today. Speaking of cancer screening, there are going to be new guidelines for cervical cancer screening, similar to what Dr. Brown has just talked about. And for the first time, draft guidelines from the U.S. Public Services Task Force allow patients to collect their own samples. Joining us now is Dr. Melissa, I think I've got this right, but you correct me if I say it wrong, okay? Haviliana,
yes.
Haviliana, I was close, okay. Haviliana, a gynecologic oncologist at the University of Kansas Cancer Center. Good morning. Now, normally, a provider does the cervical cancer screening. How does the self-collection work, and does it work as well as seeing your doctor?
So currently, there are some countries that are allowing people to self-collect at home. In the United States, when we're sort of stepping into this new approval for a self-collection for HPV, it's currently going to be something that is done at a health center. So there would be some people around to help coach people through the first time they're collecting this. I think it's still something that's a little bit in its early days, but overall the data so far is very promising that women can successfully collect a sample to get an accurate HPV test. I think one of the important points is this is not a traditional Pap smear that a physician would collect for you. So it's not looking at cytology or looking at the cells of the cervix. It's just looking at HPV. So it's not important that the sample comes from the exact right spot that a gynecologist or a family medicine provider might be collecting the Pap smear from. It's more just important to get a sample from inside of the vagina.
So now, are there concerns about user error where a patient doesn't do it correctly? It sounds like it is, but maybe with coaching that can be overcome.
Yeah, I think that a lot of people, when they initially think of this, they think, okay, when I get a Pap smear, someone is looking in there and they're, like I said, they're going to a very specific location to collect. In this test, it's not as important to collect from this very specific location. So I would sort of liken it to something like doing a home COVID swab in your nose. Of course, somebody can collect that incorrectly, but the vast majority of patients, especially with a little coaching or some instruction, would be able to self-collect accurately.
Did you just say the big C word, the COVID word, not the cancer word in this case?
Yes.
We're going to be talking about that again in a moment, too. All right, so in your opinion, is this a good collection? Is it kind of additive to what we do, or is it we're going to replace seeing your doctor and having it done?
I think it's an additive to what we do. There are a lot of other benefits to having a pelvic exam. We can detect things like fibroids, discuss things like family planning, birth control goals, when people want to have children. I think there are a lot of other positive things that come for young women going to the gynecologist. But this I think is something that is really great for patients who perhaps have a history of trauma, and a pelvic exam is just something that is going to be really difficult for them, and they're not getting screened because of fear of a pelvic exam. Reaching out to people who historically have had a difficult time accessing care. And I think it's going to just be able to let us reach a wider population, but not replace the positive relationships that women do have with their gynecologist and who are comfortable receiving pap smears in a traditional fashion.
All right, so now remind us of the guidelines. Who should get screened? When should they screen? When do you get to stop screening?
So for average risk women, they should start screening at the age of 21. Between 21 and 29, the screening is every 3 years. And actually, at that point, it's not currently recommended to use HPV as the primary screening method. It's recommended to use cytology or collection of the cells from the cervix as the primary screening method. And then from age 20 or 30 to 65, again, if you've had all normal pap smears and you're otherwise an average risk woman, you can get screened every 5 years with a combination of the cytology screening and the HPV screening, or just continue with every 3-year screenings with cytology alone. I think over time we're going to continue to shift more towards an HPV-based screening method, but currently we're still using a hybrid method.
And I'm going to guess that you're still a pretty big advocate for the HPV vaccine.
Definitely. I mean, cervical cancer is can be a really challenging disease to treat, especially if it's not caught early. And it's a wonderful opportunity to be able to prevent the problem before it even happens. Also, beyond just cervical cancer diagnoses, while we've gotten less aggressive with treating cervical dysplasia, still having to have procedures done on the cervix as a young woman before you've completed childbearing can have impacts on that as well. So just never having to deal with that issue because you got a vaccine when you were, age 11 to 12 is really wonderful.
Yeah, it sounds like a really good move. All right, Doctor, I'm going to say it right. Havliana.
Yes.
All right. Look at me roll. See, I didn't even have to have you here, Dr. Nawala, or whatever your name is. Okay, let's move from cervical cancer to prostate cancer now. Joining me today is Dr. Will Parker, urologic surgical oncologist at the University of Kansas Cancer Center, who deals exclusively with prostate cancer and uses techniques that can reduce nerve damage and protect sexual function. And in full disclosure, I am one of his patients. I've had a history of prostate cancer, so thank you for being on the program.
Very welcome.
For being my doc. Dr. Jake Fantis is a urologist at the health system specializing in men's health, including sexual health. And Dr. Gregory Nowalnik, not bad, is a psychologist at the health system's clinical director of psychology services. He's here to help unpack the connections between sexual health and mental health. Great to have you all here. Dr. Parker, could you explain what nerve-sparing procedures are and how they aim to preserve sexual health?
Absolutely. So first off, I think it's important to recognize that the nerve tissue that controls erectile function is attached to the prostate. So anytime that we treat prostate cancer, we are invariably doing something to that tissue. A nerve-sparing procedure is when we try and spare as much of that tissue as is possible in order to preserve future sexual function, but it's not a guarantee. So even when we save all nerve tissue, only around 85% of men who have good function to begin with will recover function long term. And it's just because these nerves are so tiny and small that they do suffer some damage even in the effort of saving them.
Okay. So, how successful are these procedures? You mentioned 85%. What other factors can influence that outcome?
So many things. So age, comorbidities, so particularly diabetes is a huge impact when it comes to sexual function recovery just because of what it does already to nerve tissue. Vascular disease. So coronary artery disease, as we know, is incredibly common in men in the United States. The penile arteries are smaller than the coronary arteries. So kind of as a canary in the mine, the penile arteries actually suffer vascular disease before the coronary arteries do. And so there's so many pre-existing things that can influence this one thing that we're doing when we take out somebody's prostate or radiate somebody's prostate, that it can become kind of the straw that breaks the camel's back. That where one insult is just too much and somebody may have been compensating reasonably well for these other issues, and then now it's too much.
So I know many times with the prostatectomy, you have to go in, you have to try and take out all the prostate cancer. So you take out the prostate gland. But is there a chance, if you're trying to leave the nerves behind and intact, that you could leave some cancer around the nerves?
Absolutely. So it really is a true balancing act where I kind of explain it's a continuum. On one end, if I want to maximize cancer control, I'm going to leave no nerve tissue behind, but that would be like severing the wire between a light bulb and a light switch, right? The light's never going to come on no matter what you do. Versus the other end of the spectrum where we try to save every last bit of nerve tissue, and from a probability standpoint, we may be increasing the chance we leave some cancer behind. So we really have to look at clinical features, where their cancer is, what their imaging looks like, to decide, is it appropriate from a cancer standpoint to even try?
Okay. So now, for men who may not be candidates for nerve-sparing surgery, tell us about the different options to restore sexual function after a prostatectomy or other kind of surgery that could affect it.
So there are a number of tools that have been developed to help address sexual dysfunction after surgery, from oral medications, although that's really limited to men who have some intact nerve tissue. You have to have some intact nerves for the oral medications to work, like Viagra or Cialis. There are vacuum erection devices, so mechanical pumps that can pull blood into the penis. There are injectable medications that you can inject into the penis to directly cause those blood vessels to dilate.
That doesn't sound like fun to me.
The cell rate on that's a little low.
Yeah.
And then there are implant procedures that can be done that Dr. Fantas here does to help restore sexual health.
All right, so Dr. Fantas, talk to us a little bit about these things and how common, first of all, how well do those prostheses work in the penis, and is that a successful surgery?
You know, that's a great question. If you look at the satisfaction rates after these surgeries, they're between 96 and 98%.
So that's pretty good.
Pretty high satisfaction rate. Complication rates range from about 1 to 5%, depending on, again, patient characteristics, diabetes, cholesterol issues, and then extent of their disease and whether or not they had radiation. The major benefits of these devices is that, unlike some of the other treatment options that may involve needles, they give you a reproducibly rigid erection that lasts for as long as you want. I think it's important for patients to kind of understand the sexual response cycle, that you have some excitement, and this only really takes the place of that erection portion, which comes next. You're able to control your own erection. All the sensation should remain intact after this, so you feel everything. You can still achieve a climax or an orgasm or the sensation of pleasure. The only downside of the device is that you have to deflate it afterwards, because it doesn't go down automatically like your normal anatomy would work.
All right, that's pretty helpful though. But now, what are some of the common misconceptions men have about sexual health and prostate cancer?
I think one of the big ones is that prostate cancer may cause sexual issues. I can't tell you the number of men that come in with erectile dysfunction asking if they have prostate cancer. And as Dr. Parker will probably allude to, prostate cancer is largely a disease that has no symptoms, which is, again, we talked about screening earlier, why screening for prostate cancer is so important. Something else that I get a lot is that, you know, my sex life is over, I had my prostate removed, I had radiation, there's nothing I can do. And I can tell you, I see a lot of men from different walks of life. It's unfortunate that we don't have more public information to tell people to come in for a visit to talk about all these different treatment options that we have.
So what does the typical recovery plan for sexual health look like after a prostate cancer therapy?
You know, I'd say there's not a one-size-fits-all model. There's a really good meta-analysis or a piece of literature that looks at a bunch of different studies in this space, and it's usually a combination of things. You know, I tell a lot of my patients that our erections are good for erections. And what I mean by that is giving any sort of blood flow to the penis during this recovery period not only expedites the recovery, but it can also prevent something like penile shortening after the procedure. The penis acts similarly to a muscle, and if you're not getting these nocturnal erections or erections at night, which most men get normally because of any kind of damage or stretching to the nerves or radiation, the penis becomes less stretchy in a way and does atrophy. So getting people on a program either with oral medications to increase blood flow, vacuum devices, and the injections Dr. Parker mentioned earlier rather than later is pretty important.
So what advice are you going to give to men? Because I'm going to guess some people are a little hesitant to come get help, whether it's after prostate cancer treatment or just period. So what advice do you give to folks about that?
Yeah, it's the same advice I usually give to patients for erectile dysfunction or sexual dysfunction otherwise, and it's that if this is important to you, I would seek help for this. I mean, realistically, we talked a little bit about the prosthetic. I almost equate that surgery to like a joint replacement. If you're having problems walking, you go see somebody about having problems walking. I know this can be somewhat of a taboo subject for some people, but if this is important to you, we have treatment options. Setting up an appointment just to discuss these things, I think, is the first step.
And if 95 to 100% of people are pretty darn satisfied afterwards, Well, that's pretty good. That's better than I do in the lung clinic, I promise you. So now, Dr. Nowalik, why do you think erectile dysfunction carries so much shame for men? Why is it so taboo?
You know, I think it's just our culture. You know, Western culture tends to place so much value on virility and man. You know, and I mean, we've got.
That's who I am.
I say it's almost comical how much that's at the forefront of our society. It's like real American heroes, you know, that whole thing. So it's just there. It's one piece of it, and also we're kind of conditioned, you know, and I want to use a word that Dr. Parker used earlier, that when I prepared for this, I was thinking continuum. Everything is going to fall along a continuum, and I'm going to use that word exhaustively today. But, you know, some folks are the real man, need the big truck, got to go
get that real American hero thing again. That was pretty good.
I think we could all do it. I mean, it was everywhere. But the other piece is that, you know, there are other men who at the other end of the spectrum, really the sexual performance isn't such a big deal. It's not the defining characteristic. They're more intellectually driven and more into different interests and whatnot. So, you know, you're going to see some people much more significantly impacted by this, and the idea of shame, it's largely self-imposed, because anytime that we have something where we feel less than or feel like we don't measure up to everyone else, anyway, you know, it's going to be that unfavorable identity. No, I can't go. Once you say it, that's it. It's out there. Yeah.
So what advice do you have for men then who are struggling with these feelings and their partners who do want to support them so often?
Well, you know, there's the literature out there talks about men wrestling with this, that some of the most helpful and curative avenues to explore center on control. And, you know, when you get a diagnosis like this, I think the first thing that we feel, let's do double entendre, impotent. You feel like you don't have the control, you don't have the power to deal with the situation. It happened to you. And so the more that we can empower the indivital through things like...
are looking for you.
I know, right? I'm sure. Hi, guys.
Okay, hi, Stu.
But, you know, like exercise, you know, the more that, that people, sometimes they choose to be more active, they want to get an exercise, things that actually help their prognosis. And also you see people form a sense of community around the battle against cancer, and men love a good battle. So, you know, that kind of plays into that sense of masculinity. So there are a lot of different things. And as far as engaging with the partner, it's important to recognize that sexuality is one aspect of a partnership. And we hope that maybe this can be sort of a gateway that when we talk about continuum again, some people are going to regain, you know, functioning and be all right. Some people are never going to be able to. But the idea is you don't know where you're going to fall. And so in that interim, leaning on relationships, forming connections, really recognizing that you're with somebody for more than just the 3 minutes of thrill that you're able to give them on average. Sorry. Is that just me?
Okay, he's done. He's never coming back. Actually, that's pretty good.
I did it again.
So you just said. So how can medical professionals better address the emotional needs of men dealing with erectile dysfunction? Because I think you're right. I mean, 3 minutes, okay, fine. But it still could be really important. 3 minutes to somebody.
It's a big deal, and for a lot of men, we're conditioned to, you know, you got to go find a partner, and biologically we're innately driven for this. So when you remove that, there's a lot of time that you're going to get back. So look at it in that way, that now you have the time and the ability to explore other options, but it's important to validate this loss. Oftentimes in therapy, we grieve the loss of the former self and try to really welcome this new identity and try to encourage the individual to really acknowledge the feelings, because we don't want avoidance. That's not a healthy coping skill. So kind of lean into it and recognize that, you know, the more that you can engage your support system around it, and that we normalize this, and also ask as many questions as you can of your providers. There may be options that are available that you're completely not aware of, because why would you be until you find yourself in this situation? So ask, and get as much information as you can, and see how you go from there.
That is, I think that's great advice, and for all of our folks in all sorts of situations. So we are here to answer your questions. Send them using the links on your screen, YouTube, Facebook, or email the Medical News Network. Okay, let's check in with Doc Cough. The respiratory viral system was off to a slow start, but numbers are climbing, especially flu. I'm a little nervous about COVID. I texted you earlier this week. I got 2 close family members with COVID right now, and a couple they're pretty sick. So, you know, I think, is COVID making a comeback?
You know, it is starting to, as far as I think we are seeing more trends of people going to the emergency department, and the percent positivity is starting to increase as far as COVID goes, but certainly nationally, influenza as well, and then of course all the other cough and cold viruses. Here at the health system, we have this this graph here, this data that shows the percent positives of influenza, and that was that blue line that went up at a very high trajectory. So we are seeing an increase in our percent positives, so I'm sure we are testing more as well. And then we also have our other graph, which is going to be showing you admissions with RSV, flu, and COVID. And luckily, Steve, we have had single digits for COVID admissions. We are seeing RSV up just slightly as well. But if you see that blue bar far over on the left, that is our influenza admissions here at the hospital for the week prior to last week when we have all of our data. So we are seeing an increase overall. I think in the community, we are seeing that increase as well.
So it is clear to me that we were beginning to enter this viral season. Now we got into it a little late, but that doesn't mean it can't still be challenging.
Mm-hmm. Yeah, for sure. And if you look nationally at the, I like using the marker, the graph of, again, people that are going to an emergency department or urgent care for ILI or influenza-like illness. You can see that there is a steep increase. We are over kind of the epidemic level at this point in time. So people are getting those illnesses. They are going to the doctor's office or the ER to get evaluated. But what I would say is, you know, this is our last show for a little while. I think it's important to rerun everything and talk about how to keep people safe. Number one, prevention. There is still time for vaccination, influenza vaccine, updated COVID vaccine, and again, RSV vaccine if you have not received one. Last year was the first it was available for those over 60. It has shown great safety and effectiveness at keeping people out of the hospital and from having to go to their doctor's office. So prevention is the best. It's not too late to get vaccinated. Please go get vaccinated. Those other pillars of infectious disease or infection prevention, like we've talked about, if you feel unsafe, you know, it's always okay to wear a mask. That will help reduce your chance of infection. If you are sick, don't go out. It's very important to get good sleep, good nutrition, and try to stay active. That will all help boost your immune function. Also, washing hands. We don't emphasize this enough. Washing hands frequently and adequately. Either use soap and water or alcohol hand sanitizer, and please avoid putting your hands in your eyes, your nose, your mouth. That is probably how the majority of people are getting infected when they are out in the community, touching high-touch surfaces like desks, tables, chairs, if they're out eating, or handrails or door handles as well. And then, of course, have a plan, especially if you are high risk. It is vitally important to have a plan. If you are symptomatic, please get tested, either at your doctor's office. We know that there are those home tests available for both influenza A and B as well as COVID. They do have a triple home test. You may have to test 2 to 3 times or 2 to 3 days in a row to get a diagnosis, but it is vitally important to have a plan and talk with your physician. If you can and you are high risk for disease, you need to get on those antiviral medications, Tamiflu for influenza, and then for COVID, it is Paxlovid. And again, we are not using hydroxychloroquine. I would like to bring up that one of the earliest papers from 2020 showing a benefit of hydroxychloroquine in treatment of COVID-19 has been retracted. That investigation has been going on since 2020, so 4 years retracted. This was the second most cited paper ever to be retracted. There were ethical concerns, and there were even concerns about whether the patients had enough time to have all the data gathered and analyzed. Luckily, also, a couple of the authors have requested their names be taken off that paper. So, Steve, we are trying to continue to provide you with the most up-to-date and accurate science information, not clouded by opinions or unethical practices. This is one of those papers. I'm glad it has been retracted. We will continue to stick with the science and promote that and endorse that as much as we can.
I love facts over fiction, and I loved our little video thing up there that had the big retracted on that article. Because
yeah, that's from the journal.
So much. We heard about it a lot. We got challenged about it a lot. And oh, wait a minute, it was a falsified paper.
Yes.
And authors want their names off. You see, truth over lies. That was fiction. we told you the truth. We'll still
Absolutely.
keep doing that. And
Yes.
the rules of infection prevention and control, where do they go, Hawkeye?
They go with you wherever you are.
Excellent. All
Absolutely.
right. We know that many of you have questions. Let's head to Studio B with Alexis.
We have a couple of questions and a comment from Jeremy Yenser. He writes, it sounds like this could definitely affect sexual ability, but does it also affect desire or lack of it after surgery? And Jeremy writes, bonus points if you answer it in your real American hero voice.
Okay,
And he
well,
says,
I guess this is you that has to answer that question. You've
And
been called out.
one
You're
more.
never coming back. You've been called out.
Oh, it's just is there more?
Yes, there's more. He says, thank you so much for talking plainly and clearly about what could be an awkward topic people would avoid.
So we have to have him back. Thanks for that.
I feel like I
Yes.
talked awkwardly about it,
Yeah,
but
well,
you know, that's fine.
You did okay. You were the real American hero. You're
right.
the hero, man.
All right,
Let's
there
hear
we
the
go.
voice. Let's do it again.
All right, so real American hero feels like I don't have the answer because I don't work with this as commonly as these fine gents over here. So I will ask them about the interest.
Yeah, I think sexual desire is completely separate, and there are a lot of variables here after prostate cancer treatment. This has a lot more to do with hormone levels. However, I can tell you that a lot of men have desire issues because they cannot necessarily get an erection. So the interplay between erection, desire, etc. is really important to unpack. I do send a lot of people for sexual therapy in addition to putting them on either medications for erections, and if their desire is not restored, we do hormonal evaluations as well.
Yeah, I'd also like to just kind of clarify, when we talk about prostate cancer treatment, we focus on sexual function. Really, we're talking about the mechanics of getting an erection. There are two other pieces to this that we've kind of alluded to at times. There's orgasmic function, which is really sensory that we're not impacting. And then there's desire or libido drive. That's influenced by so many other factors. And often men do struggle with that, more related to the coping and kind of the situational depression, honestly, that can develop from a cancer diagnosis.
Yeah, I would ratify that.
Yeah, I was going to say, I think that the biggest concern you're going to run into is that identity of less than or damage, that I'm not the man I was.
I'm not the girl of the
and the reality is that you're every bit that man. This is one aspect, a big one, albeit. But we want to try to encourage the individual to recognize that you're still yourself. This is one aspect of your functioning, and that the sooner that you can kind of get over the hump by really acknowledging that this is what's happening and trying to inform yourself and find options. I think there are a lot of options, sounds like, to get you back in. I'll admit I've been listening to a lot of this because my PSA was elevated last year, and I'm like, and it turns out it was just road cycling and just kind of beating on things so much that I have an enlarged prostate. Great.
Yeah,
I feel like I'm in a meeting
My
here.
advice to all men is don't go on your bike for 5 days prior to getting your PSA level done. It makes that a pretty significant, at least 10%, 15%.
Yeah.
All right, Alexis.
Ruth Ellen has a quick question. She wants to know if you could just remind again, how much time do you wait between COVID vaccines?
Oh, you bet. Where'd Hawkeye go? Really, it's at least 3 months. If you've had a COVID vaccine, actually 6 months. If you already had a COVID vaccine, you don't need to get one for another 6 months. And there's not a lot of data around that. And that's really if you're in a vulnerable population. And right now, the CDC is saying a year if you're otherwise young and healthy. As you get closer to 60 years old, you may want to do it, or you have other comorbid conditions, transplant, cancer, etc. You may do one every 6 months. Generally, we tell people you don't really have to wait after you've had a COVID diagnosis to get a vaccine, but we tell you to wait about 3 months because generally having COVID gave you some protection, and having that shot, we're going to feel good right after you had COVID. So you might want to wait about 3 months if you've already had COVID.
Great discussion.
All right, any other questions?
We do have, let me see, one more. Jean Reardon wants to know, does hormone treatment affect this?
Does hormonal therapy affect prostate cancer? Let's talk about testosterone replacement in prostate cancer.
Now that's almost a third rail conversation.
It sure is.
There's this whole spectrum in terms of what we think about with hormonal therapy and prostate cancer. It used to be felt that testosterone caused prostate cancer, which we know is not true. In fact, low testosterone levels can lead to more aggressive prostate cancers, even though we do leverage that to treat cancer. Men who have low testosterone levels should be replaced if it's needed.
All right. So this has been a great discussion with a little bit of humor. on a pretty hard subject, no pun intended there. I'm grateful to
you, John.
I stumbled into it. I'm grateful to all of our guests for being here. I want to hear final thoughts before we go. Dr. Nwalnik, and you can come back.
Thank you. I appreciate that. I don't know if I want to after this. I go out on this. This is the way. You know, in terms of final thoughts, I think that really it's just important that you're asking the right questions, and there are no wrong questions. So the more information that you can get around this, and if you notice that you're struggling with depressive feelings like you're not yourself, can never be yourself again, any of these really sweeping extreme thoughts, I encourage you to reach out for a mental health provider to try to get some support through this, because this is not easy. And so we're here to help.
Dr. Fantas.
You know, ED is a almost ubiquitous condition. Almost 80% of people by the 7th or 8th decade of life have it. There are things we do to expedite it with different treatments, but it's a very common problem. I think it's important to acknowledge that, and then if this is important to you, to seek medical advice earlier rather than later.
Don't ignore it. Dr. Parker?
Yeah, two thoughts. One, we saw that study about screening. Prostate cancer was part of that. PSA screening did improve mortality rates, so get your PSA tested. But the second is, it is not wrong to advocate for your sexual health. I see a lot of men, when they're diagnosed with cancer, think that I've got to focus on my cancer, we'll forget about my sexual health and my sexual life. If it's important to you, as Dr. Fantas said, it's important to you, and there's nothing wrong with that.
You know, we all have to have delicate conversations sometimes. You had to tell your children that there wasn't really a Santa Claus. But really, one of the more delicate ones, yeah, sorry. Jeez. You're one of those. And you're one of those. So at the end of the day, though, this is just another delicate conversation that we have to have, because men's sexual health is kind of swept under the rug, and we're all assumed to be the American hero. And the reality is, very few of us are. We all bring to our lives all our foibles, all of our mistakes, all of our errors, all of our thoughts, all of our feelings. And at the end of the day, it makes us who we are. But sometimes we need a little help with that, and that's okay. And you see, together we call that faith, hope, and science. Faith in each other, the hope we can get better, and the science that can help deliver it, especially the real science, and not like the science that had to be retracted on the hydroxychloroquine paper. All right, audience, thanks for being here today. Remember, faith, hope, and science. We'll be back with you soon enough. In the meantime, happy holidays, Merry Christmas, and when you need some help, go get it.
Some doctors call this the fourth quarter binge, with parties, and more holiday parties. I'm Alexis Del Cid. On the next All Things Heart, what drinking more than usual for just a single night can do to your heart.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.